Hi, my name is Clinical Clinus and you're watching the video on the surgical management of patients with strabismus. Now you're aware that we can perform surgery on the extraocular muscles to achieve alignment of the visual axis. Now when a surgeon goes about performing surgery on these extraocular muscles, one of two things is going to happen. One is we're either only going to achieve a cosmetic outcome whereby the angle of the deviation will be improved, but the patient will not have gained BSV. The other alternative is that the patient will have an improvement in the alignment of visual axis and will gain BSV. That's a functional outcome. In order for us to work out whether the patient is likely to have a functional or cosmetic outcome, we need to determine if a patient has the potential for BSV. Patients with the potential of BSV generally will have a prognosis of having a functional outcome. Patients, on the other hand, who have no potential of BSV, well then the aim is to purely have a cosmetic outcome, an improvement in the size of the deviation. Now, in order for you to determine the prognosis of your patient's post-op outcome, you need to do a series of preoperative assessments, and I've listed here a number that are critical in determining a likely outcome of surgical intervention. Now, over to the right, I mentioned that there are several other aims for surgical intervention of patients with strabismus. For the purposes of this subject, our primary aim is simply related to achieving a cosmetic outcome or a functional outcome. The aims here to the right are more related to patients who have incumbent strabismus. However, I do want to mention the last point there around expanding the visual field. When we operate on ESO or EXO deviations, we will have an impact on the visual field. Now, if you can imagine an ESO deviation or a patient with an ESO deviation is going to have a visual field that is contracted. So when the strabismus is operated on, there will be an expansion of the visual field. This is an added impact or a positive impact of surgery for patients with ESO deviations. However, the opposite is true of a patient with an EXO deviation. An EXO deviation patient will have an extended visual field because the eye is turned out. And as such, when we surgically intervene with these patients, we will reduce the visual field and bring it back to normal levels. As such, be sure you warn your patients of potential changes to their visual field, as they won't be expecting this given that they've come in for surgery for their strabismus. Okay, before we commence discussing the various surgical options we have in treating patients with strabismus, let's go back to some of the key principles regarding how we move our eyes. Now, you're well aware that a muscle that is contracting will produce a force that rotates the eye. This rotational force relates primarily to two things. One is the muscle force, which is depicted here by the arrow, and the other is by the moment arm or the lever arm, which is here, which is reflected by the distance between the tangential point here and the centre of rotation here. What's important to recognise in relation to this rotational force is that muscle force is related to muscle slack. So how slack the muscle is or how tight the muscle is. And if we take a look here at the graph, what we can see is this scale here has increasing muscle force and this scale here has increasing muscle slack. And what we can see is that the tighter the muscle here, the greater the muscle force, and therefore the more slack a muscle is, the more reduced the force is. And so it's through this mechanism that we can change the alignment of the eyes. We can slacken a muscle or tighten a muscle in order to correct a strabismus. Now, there are two mechanisms utilised in strabismus surgery. Others are you could reduce the length of the moment arm or the lever arm in order to change the deviation. And also, you can change the vector of the muscle force by moving the muscle insertion. So this relates to transposing the muscle to another position. So this relates to not only transposing the muscle to another position, but at another angle. Overall, we have weakening and strengthening procedures for strabismus surgery. Here I've listed some surgeries that relate to weakening extraocular muscles and some surgical procedures that relate to strengthening extraocular muscles. Now, we're not going to go through all these procedures. For concomitant strabismus, the most important ones we need to learn are about the recession procedure and about the resection procedure. The recession is a slackening procedure, so it weakens the extraocular muscle. The resection relates to strengthening and tightening the extraocular muscle. The other procedures we'll learn more about next semester. Now, just before we proceed to discussing the recession and the resection procedure, let's just go a step back and discuss the fact that before the surgeon operates on the muscle, the surgeon needs to expose that extraocular muscle that they need to operate on. Now, depending on surgeon preference, surgeons will either make a limbal incision to gain access to the extraocular muscle or a fornix incision. Here we have a limbal incision where the limbus is. Here we have a fornix incision, again where the fornix is. And here we see the extraocular muscle has now been exposed and has been hooked onto this instrument here. Once the extraocular muscle is exposed, the surgeon will then proceed to performing the recession or resection depending on what's required. Let's start off now with the recession procedure. As I indicated earlier, it is a weakening procedure, and so we're aiming to weaken the muscle but without causing limitation of movement. And what I mean by this is you don't want to cause an underaction from the recession that is performed. So in this example, if a lateral rectus is recessed, you don't want to have an underaction of the lateral rectus post-operatively. This won't occur unless excessive surgery has been performed. Okay, how do we perform a recession procedure? Let's take a look at the image up here. Here we have a lateral rectus. This is the the original position of the insertion. In order for a recession to be performed, the tendon is severed at this insertion point and the muscle is moved back and reinserted in a new position further behind the original insertion. Now, the distance between the original insertion and the new insertion will be dependent on the size of the deviation. So what we see here is that there is a smaller recession of the lateral rectus of this eye as compared to the recession of this eye. So this eye had a larger angle strabismus as compared to this eye here. Now if we have a look at the image below here, here is the original insertion of the lateral rectus, and by moving the extraocular muscle back, we slacken the lateral rectus. And so we weaken its action, and through this, we create a change in the rotation of the eye. Now, if we recess a lateral rectus specifically, what is the impact on the strabismus? The easiest way to imagine this is to think about the opposing forces of the medial rectus and the lateral rectus. The medial rectus is an adductor, and the lateral rectus is an abductor. So if you weaken the abducting effect of the lateral rectus, the eye will rotate inwards in response to a recession. So a recession of the lateral rectus will have the effect of improving or treating an exodeviation. The outcome will be different if you recessed a medial rectus. Recessing a medial rectus will have the opposite effect. It will improve a esodeviation. Let's now move on to the resection. The resection is a strengthening procedure, and overall what we're doing in a resection is shortening the extraocular muscle and thereby tightening the extraocular muscle. To tighten or shorten the extraocular muscle, a component of the muscle needs to be excised. So if we take a look here, let's assume again this is a lateral rectus. We can see that a piece of the muscle has been removed. In this example here, a larger piece of muscle has been removed. So again, we're dealing with a larger deviation here and a smaller deviation here. Now, unlike the recession, the extraocular muscle is returned to the original position of the insertion. Now, just as we said in the recession, if you do excessive amounts of recession, you can end up with a limitation of eye movement. The same can happen with the resection if you tighten the extraocular muscle too much. The difference now with the resection is if you tighten a muscle too much, the limitation of eye movement that you'll see won't be in the direction of that extraocular muscle's action, but in the opposite direction. So if we use this example of the lateral rectus resection, if we have a tightening that's gone too far, what we'll see is a limitation on adduction. So it'll appear as though there is a medial rectus underaction, but it's actually that the lateral rectus is tight and is not allowing the eye to completely rotate on adduction. Now, can you work out if you resected the lateral rectus of the right eye, whether you're aiming to improve an ESO or an EXO deviation? Let's take a look at the image down here where we've got the lateral rectus which has been tightened, and here we have the medial rectus. This tightened lateral rectus will cause the eye to rotate outwards. So a resection of the lateral rectus will assist or will aim to improve a ESO deviation. Again, the opposite would be true if you resected the medial rectus, then what you're aiming to do there is improve an EXO deviation. Now, when performing recession and resection procedures to improve the alignment of patients, it's not sufficient usually to operate only on one extraocular muscle. The deviation has to be extremely small to operate only on one extraocular muscle. We're operating on two extraocular muscles. Now, the decision has to be made whether bilateral surgery is performed or unilateral surgery is performed. Unilateral surgery is when we perform the procedure on the one eye. So in this instance, you would perform a procedure on the lateral rectus and a procedure on the medial rectus of the same eye. One will be a recession and the other will be a resection. For bilateral surgery, you're operating on an extraocular muscle from the right eye and one from the left eye. So as an example, you might operate on the two lateral recti. There are various factors that influence a surgeon's decision as to whether they do unilateral or bilateral surgery. For the purposes of this subject, I want you to utilise one principle in determining which one to recommend. And this is based on determining whether the deviation is basic or whether there is a near distance disparity. What I mean by this is determining whether there is a difference in the angle of deviation between the near distance and the far distance. A significant difference is considered one where there is a difference of at least 10 prism diopters between near and far. Now, the principle goes that the medial rectus as adductors are primarily utilised at near, and the lateral recti as abductors are primarily used in the distance. So when you perform surgery on the medial recti, you're having a greater impact at near, and when you're performing surgery on the lateral recti, you're having more of an impact in the distance. So if, for example, you have a basic deviation, so let's say you have a right esotropia of 30 diopters at near and 30 diopters at far, it is recommended that you perform unilateral surgery. So what this means is if it was a right esotropia, we would resect the lateral rectus and recess the medial rectus, and therefore we would have a similar impact at near and far, which is what we want given that it is a basic deviation. The alternative is that we have a deviation with a near distance disparity. So let's say, for example, we have an exodeviation that's greater in the distance. Now, given that the deviation is greater in the distance, we want to have more of an effect in the distance. Which muscles work more in the distance? The lateral recti work more in the distance. So in this instance, we'll operate on the two lateral recti, one from the right eye, one from the left eye. Because we have an exodeviation, we will recess those two extraocular muscles. And now we've performed a bilateral lateral rectus recession in order to target the distance deviation more than the near deviation. Let's now move on to the amount of surgery. How do we determine the amount of surgery? Well, there's three options we have. We can either fully correct the deviation, we can undercorrect the deviation, or we can overcorrect the deviation. A few things will determine or will influence our decisions with regards to this. One is, does the patient have the potential for BSV? If the patient has the potential for BSV, then full correction is an ideal option for these patients. If, however, the patient doesn't have the potential for binocular functions, then what we know is that the patient post-operatively is simply going to have a cosmetically improved deviation. And so what we need to consider is what would happen to this deviation over time. Over time, the eye exodrifts, particularly when we become presbyopic and there's hypoaccommodation. So if you have an ESO-deviation, it is preferred that if there's no potential for binocular functions, that you maintain a residual ESO-deviation post-operatively to allow for that exodrift over time. In relation to an exodeviation, in this instance we would prefer to overcorrect and create an ESO-deviation, again for the same reason, to allow for the exodrift that occurs with age. Let's have a look at the couple of examples that I have here. The amount of surgery is determined by the size of the deviation, which is determined by the prism cover test. So here we have a 35 diopter esotropia. Now, we could fully correct this esotropia, in which case we would operate on the 35 diopters. The other alternative is to undercorrect, which leaves the patient with a residual esotropia, or we could overcorrect, which leaves the patient with a consecutive exotropia. Now, really, for an ESO, the two options that we have is fully correct if they've got binocular single vision and undercorrect if they have no potential for binocular single vision. However, should there be issues with the suppression scotoma, you may need to consider overcorrection. And what I mean by this is, say for instance that patient had diplopia with undercorrection and diplopia with full correction, but single vision with an overcorrection because there is a suppression scotoma here, well then you would need to overcorrect. So you also need to know, is there suppression, where is that suppression scotoma, so that you can make sure that your patient doesn't have post-op diplopia with surgical intervention. Let's now do the same with an exodeviation. Here we have a 35 diopter exodeviation. Full correction would mean operating on the 35 prism diopters. The other option we have is a overcorrection, in which case we make the patient ESO, or an undercorrection, which means the patient remains with an exodeviation post-operatively. So as before, the best options here are to fully correct the patient or to overcorrect the patient. Now, the thing with exodeviations, particularly with intermittent exos who obviously have the potential for BSV, it is still preferred to overcorrect these patients rather than fully correct them. The reason is that by overcorrecting an exodeviation, you will account for the exodrift that occurs with aging. And intermittent exos have a high risk of recurrence of that exodeviation returning with time. So if you push them into ESO, they're less likely to recur as the patient gets older. And again, even though an overcorrection may be desirable, you can't do it if it gives the patient post-op diplopia. So the key is to individualise the treatment of your patient dependent on your clinical findings, dependent on whether they have potential for binocular functions, whether they don't have the potential for binocular functions, whether there's a suppression scotoma, how long that is, etc., etc. Okay, and finally, how does a surgeon determine how many millimetres of recession or resection to perform? We have here Parkes tables, which guides the surgeon as to how many millimetres of recession or resection to perform. Now, in order to use the table, you first need to know whether you're going to perform bilateral or unilateral surgery, and obviously the direction of the deviation. So let's take, for example, earlier we said we had that right esotropia that was 30 diopters at near and 30 diopters at far. And we're going to do unilateral surgery, a recess-resect procedure of the same eye. What we do is we use this particular section of the table where it says monocular surgery, so unilateral surgery. I indicated that the patient had a right esotropia, so we're going to look at this section of the table. And we can see it's indicating we need to perform a medial rectus recession and a lateral rectus resection. In terms of the amount, if we were doing a full correction of 30 diopters, then a 4.5 millimetre recession of the medial rectus would be performed, and a 6 millimetre resection of the lateral rectus would be performed. If, on the other hand, we look at the other patient where we had the exodeviation that was greatest in the distance and we want to do bilateral surgery, we have a look at this side of the table, binocular surgery, which is bilateral surgery. We have an exodeviation, and we want to do a lateral rectus recession. Remember, we want to do the recession because it's an exodeviation and we want it to have greater impact in the distance. So again, if it's a 30 diopter deviation in the distance, then we're going to perform 7 millimetre recession on both the right and the left lateral rectus. Okay, that brings us to the conclusion of this video. Thank you for watching.